Hello and welcome to this video on disorders of motility, continuing our lecture on chapter 38 on alterations of digestive function. So we'll start off with what dysphagia is, and this means that we have a difficulty swallowing and it can be painful, and we can classify it as either having mechanical obstructions or being more of a functional disorder. So when we talk about mechanical obstructions, it means that it could either be more intrinsic, meaning it's in the wall of the esophagus. So this could be in the form of a tumor or a stricture. Maybe there's some type of herniation or an outpouching of the esophagus. Or it could be more extrinsic, meaning we have something external to the esophagus that is pushing on this tube. And typically that's going to be a tumor. As far as functional, we are going to have some type of neural or muscular disorder. And that is going to interfere with our voluntary swallowing, or peristalsis, in which the esophagus uses muscular contractions to bring the food down to the stomach. And that may be due to a cerebrovascular accident, Parkinson's, MS, muscular dystrophy, or achalasia, which brings us to our next term here. It's a type of dysphagia, and this is really when we have a failure to relax that lower esophageal sphincter. And you can see that, I had to pop this image in, you could see that in this image over here, where that lower esophageal sphincter, that is essentially the gate protector of that food in the esophagus moving down into the stomach. And that is because we lose the inhibitory neurons within that myenteric plexus in the muscularis external layer, and therefore get atrophy of that smooth muscle in that layer in the middle and lower portions of the esophagus. So what starts to happen is we may get the food, really the bolus, accumulating here in the lower esophagus and cause dilation to take place. And the reason this all happens is because those myenteric neurons that belong to the myenteric plexus get attacked by immune cells. And if this continues and becomes chronic, then we may need surgery in order to dilate the lower esophageal sphincter so we can allow that food to pass. So what happens when these pathologic processes cause dysphagia? We're going to have some manifestations. We'll have stabbing pain at the level of the obstruction, discomfort after swallowing, regurgitation of the undigested food, an unpleasant taste sensation, and then the body may say this food has to go somewhere and may cause vomiting. Aspiration can take place and weight loss because the food is not moving into the stomach and of course right after the intestines, and we're not able to absorb these nutrients. And so we can basically go into a state of anorexia and starvation. A person may also experience spasm of the esophageal muscles while they're eating or drinking. And we also need to be careful when they're laying down because one of the risk factors for that can lead to aspiration is when they are laying down, and this can lead to the aspiration and coughing and pneumonia. So obviously when we see these clinical manifestations, it may lead us to believe someone has dysphagia, but we can also use some imaging to be able to visualize the esophagus and see if there's any structural defects taking place. And if necessary, we can also use esophageal motility testing and esophageal endoscopy so that we can look at the mucosa as that inner layer of making contact with the lumen and take some biopsies. So how do we treat it? We can manage it by eating smaller meals slowly so that it can move through that smaller lumen through the lower esophageal sphincter, and also taking in fluids with meals, sleeping with your head elevated so that we don't get regurgitation and aspiration. Moving along in the alimentary canal, now let's talk about gastroesophageal reflux disease, or GERD. So rather than only talking about the esophagus or the lower esophageal sphincter, now we're going to involve the stomach. And this is when we start to have a reflux of that acid and the pepsin and bile salts from the stomach into the esophagus that causes esophagitis. Now, there are two different types of GERD. There is our physiologic reflux, which means the reflux takes place, but it doesn't cause any symptoms. And then we have NERD, which is non-erosive reflux disease. And that's when we have our symptoms of reflux, but there's no visible or we have minimal esophageal mucosal injury. So we can call this also a functional heartburn. So why do we have this problem? Well, we're going to take a look at that lower esophageal sphincter again. You could see that we do have some musculature that is more internal and external, but essentially we have an abnormal functioning of this LES. It could also be due to issues with our esophageal motility and our gastric motility, or the emptying of the contents. And this could be brought about because we have vomiting taking place, coughing, lifting, bending, someone being obese or pregnant, which could cause increases in abdominal pressure and contribute to the development of this reflex esophagitis. And this could also be linked to, let's say, somebody being obese or pregnant. When we have that much pressure in our abdomen, we can develop a hiatal hernia, which I'll elaborate on in the coming videos. But essentially, a hiatal hernia is when we have a part of the stomach that pushes up through the diaphragm, and it's usually in this area where the esophagus is moving down into the abdomen. And that could cause a weakening of the LES. In another instance, we may have highly acidic gastric contents, or we may contain bile salts and pancreatic or intestinal enzymes due to some type of reflux from the intestines moving into the stomach. And that could also cause a reflux esophagitis that can be really severe because it could cause mucosal injury and inflammation within this area. And we may be familiar with some of the manifestations of GERD. It's going to include heartburn or pyrosis, acid regurgitation, dysphagia, chronic cough, asthma attacks, laryngitis, and upper abdominal pain within 1 hour of eating. And symptoms can worsen if we lay down or for whatever reason we have intra-abdominal pressure increasing. And someone with this condition may also experience that it worsens if they are to have alcohol or acid-containing foods such as citrus fruits like oranges or anything that has lemon within it. So the way we typically treat this is we give proton pump inhibitors, and these are the agents of choice to control the symptoms and heal that esophagitis, but we can also treat it with antacids and H2 receptor antagonists. And just another note that people can also develop eosinophilic esophagitis, which is going to be an idiopathic chronic inflammatory disease in which those eosinophils, the white blood cells, are going to infiltrate and cause atopic disease, usually stimulating someone to have asthma and food allergies. And so if we are suspecting this type of disorder, we can do an endoscopy with biopsy so we can differentiate it from GERD. And because they have such similar symptoms, we need to know this so we can use different treatment methods. Although in some cases, we may also give proton pump inhibitors. So now we can go into detail on hiatal hernias. Like we said, this is going to involve the diaphragm in which the esophagus passes through in order to join the stomach. But we have a protrusion of part of that upper stomach through the diaphragm into the thorax. I've seen within our cadaver labs, even the entire stomach completely in the thorax, so that is possible. But let's talk about these 3 different types of hiatal hernias. So first is going to be our sliding hernia, which is what we see pictured over here. And what we're seeing is that the visceral peritoneum is going to stay intact and it restrains the size of the hernia. And so we don't really see a ton of the stomach moving up into this area, but maybe just a little push through. And this is actually pretty common, but is usually insignificant because the contents are not trapped. Next, we have our type 2 hernia, which is a paraesophageal or rolling hernia. And this is when the membrane becomes thinner or defective and is going to allow the peritoneal sac to protrude into the posterior mediastinum. And we have a negative intrathoracic pressure that's going to cause it to then enlarge. And in this case, contents may become trapped. So if it progresses and becomes larger, then they may need surgical treatment. Our last type is known as a type 3 or mixed hiatal hernia. And this is when we have a combination of sliding and the paraesophageal hiatal hernias taking place at the same time. And this is pretty rare or less common to take place, and it tends to happen when we have other diseases going on. So of course, depending on which type we have taking place, we'll see different clinical manifestations. For instance, the sliding we said is typically asymptomatic, but it can get more severe, and if we develop ischemia, that can cause necrosis to take place. We do see this more commonly in people that are over 50 because we might have some muscle weakness within the diaphragm, and to treat it, we like to be conservative, but we can do things like eat small and frequent meals, avoid tight clothing, and control our weight. And as a last resort, like we said, sometimes if it becomes enlarged and contents are trapped or it's causing ischemia, we do need to have surgery in order to put the portion of the stomach back below the diaphragm. Next up is gastroparesis, and this is when we have delayed gastric emptying in the absence of a mechanical gastric outlet obstruction. And this can be idiopathic. It is associated with diseases such as diabetes mellitus, surgical vagotomy, or fundoplication. And the pathophysiology is not well understood, but the theory is that there may be some abnormalities of our autonomic nervous system, and the smooth muscle cells or the enteric neurons, meaning the neurons within our GI tract, are going to not function properly, or it could also involve the GI hormones. And the symptoms will include nausea, vomiting, abdominal pain, and postprandial fullness, which means we have a fullness after we finish a meal, or bloating, which I think kind of makes sense as we have all of this chyme building up within the stomach. So to treat this, we can use dietary management, prokinetic drugs, or electrical stimulation or surgery. Now, sometimes we have pyloric obstruction or gastric outlet obstruction, and that's going to be when we have a blocking or narrowing of the opening between the stomach and the first part of the intestines known as the duodenum. And this could be acquired or congenital. When it's acquired, it could be caused by a peptic ulcer disease, which we're going to get into in the next video, or carcinoma near the pyloric area. Also, our duodenal ulcers are going to be more likely to cause the obstruction because they are located closer to the pylorus than a gastric ulcer would. And you may be wondering, well, how can an ulcer cause the narrowing here? And that's because when an ulcer forms, it could cause inflammation, edema, spasm, fibrosis, or scarring within that area that could lead to a narrowing of this pylorus. And then, of course, if we have a tumor growing in this area, it could cause obstruction as well. And some of the manifestations that can develop then are epigastric pain and fullness, and nausea and vomiting. And the nausea and epigastric pain may occur as the muscles of the stomach are contracting, trying to get that chyme to move from the stomach into the duodenum, basically surpassing that obstruction. And so the food is going to fill up in the stomach, and this creates a feeling of fullness, which is going to cause a rolling and jarring that produces a slushing sound of the stomach called succussion splash that can cause vomiting of undigested food with no bile present within it. These patients may also notice that their stools are infrequent or they're very small, and that makes sense because their food is not moving from the stomach into the intestines to contribute to the making of feces. And with prolonged obstruction, malnutrition, dehydration, and extreme debilitation, we can cause hypokalemia and hypochloremic metabolic alkalosis to develop because we lose that gastric potassium and acid. To To treat this, we have conservative management. We are going to possibly use a large bore nasogastric tube so that we can aspirate the contents from the stomach, and that will help to relieve the distension. And we can give fluids and electrolytes to rehydrate the patient. And we can have surgery if necessary to place a pyloric stent within this area to keep that lumen open for contents to move through if we need to treat gastric carcinoma. The last topic we'll discuss as far as a disorder of motility will be intestinal obstruction. So this is a condition that's going to prevent that chyme from continuing through the intestines. Our small intestines more commonly will become obstructed in comparison to the large intestines because the narrow is more narrow, and we have our different forms. We've got our simple obstruction, and this is a mechanical blockage of the lumen, and this could be caused by a lesion, which is most common, and we usually say this is an acute obstruction. It could be a hernia, which we see pictured over here, in which the intestines protrudes through a weakness that we have within the abdominal muscles through the inguinal ring, and I have a better depiction over here where you can kind of see where that inguinal ring is and the weakness would be, and so the intestines is moving through that area. Or we can have constrictions from adhesions, and these could be caused due to a irritation from having surgery, trauma, or if someone has Crohn's disease. And this is most common within the small intestines as well. Another cause could be a volvus, and this is when we have a torsion taking place where there's a twisting of the intestines that can then occlude the blood supply to the area. And we tend to see this happen more with middle-aged to elderly men. And then lastly, pictured here, we have intussusception, where we have a telescoping of one part of the intestines into another, and this causes a strangulation of that blood supply. And we tend to see this more in infants and babies, so around the age of 10 to 15 months. Now, when we have a chronic obstruction, it's usually going to be due to something that's associated with a tumor or an inflammatory disorder, and usually involves the colon. Or we can classify something as being a functional obstruction or paralytic ileus. And with this, we have a failure of intestinal motility because there's a functional motor paralysis of the digestive tract that is secondary to neuromuscular failure, which usually takes place after some type of intestinal or abdominal surgery, if someone has pancreatitis or hypokalemia. And because the bowels are not moving due to that failure of motility, we have fluids and gas that accumulates, and that stretches the bowel walls, causing vomiting, decreased bowel sounds, and constipation. Okay, so now let's talk a bit more about the pathophysiology and the clinical manifestations of intestinal obstruction. And we're going to separate this into small intestinal obstruction and large intestinal obstruction. So starting with the small, we see that these types of obstructions are usually due to adhesions about 75% of the time, hernias about 10% of the time, tumors about 10% of the time, and then we have mesenteric ischemia and Crohn's disease that are going to be to a lesser extent. And we started off having some colicky pains, which can then progress to nausea and vomiting. So these pains are developing because the intestines first becomes distended, and we said with stretching we're going to start to feel pain. And we will also, with this distension, start to decrease our ability to absorb water and electrolytes. So we said nausea and vomiting will follow that, and that vomiting is going to produce severe fluid and electrolyte disturbances. We start to see a decrease in the nutrient absorption. We're going to see a decrease in our carb reserves and ketosis. And because of that fluid imbalance, we can then develop dehydration. And with that is going to come a increased hematocrit. We get hypotension and tachycardia. So this all is going to contribute to our metabolic alkalosis, because we're losing hydrogen from the gastric juices during the vomiting process, and more within the lower or distal part of the intestines, we see more of a metabolic acidosis because our bicarbonate from the pancreas and our bile can't be reabsorbed. And this is also progressed because of the fact that we don't have our nutrients, namely our carbs, which causes starvation or ketosis. From that distension, we're also going to place pressure on the diaphragm, which lowers our respiratory volume, causing atelectasis and eventually leads to pneumonia. That prolonged increase in intraluminal wall tension can also decrease the venous return and our blood fluid, which can then cause disruptions leading to perforation and edema, increasing our capillary permeability and releasing toxins, leading to peritonitis. And contributing to this could also be bacterial translocation across the mucosa to systemic circulation that can lead to, it's not pictured here, but that can lead to sepsis. Let's focus a little bit on the large intestine obstruction as well. Most of these are due to colorectal cancer, about 90%. So that is majority of cases. Other reasons could be volvulus, diverticular disease, which we're going to talk about later on this chapter, or other causes such as a hernia or irritable bowel disease. And this overall is going to be a less common type of obstruction in comparison to small, like I said, because we have that smaller lumen. And another type of obstruction is going to be acute colonic pseudo-obstruction, also known as Ogilvie syndrome. This is rare and causes a massive dilation of the colon because of an excessive sympathetic motor input or decreased parasympathetic motor input, and there is no mechanical obstruction present. And this only really happens in people who are critically ill and are immobilized older adults. So all in all, intestinal obstruction is going to cause shock, perforation, if it continues, fever, peritonitis, dehydration, and hypokalemia and hypocholeremia. And some things to always keep in mind is we will need immediate surgery if there's strangulation, a complete obstruction, or perforation taking place.